Morning, everyone. Welcome to the Friday morning webinar. Everybody's favorite place to be on a Friday morning, I'm sure. So thanks for joining the Central East Regional Cancer Program. We're here with Dr. Hugh Kendall and Dr. Becky Ray to present to you on some of the changes that are coming for FIT in the Colon Cancer Check program. We're calling it FIT 2.0, very catchy name. So hopefully you find it all very catchy. I'll just do a brief introduction of Dr. Kendall and Dr. Ray. And Caitlin, do you want to throw the slides up when you have a second too? And then we have also a land acknowledgement for this morning. Important, especially acknowledging that it is National Indigenous Peoples History Month. So wanted to make sure we start the session in a good way. So I will start with a quick introduction. So Dr. Hugh Kendall is a general surgeon who graduated from McGill Medical School in 1990 and completed a University of Toronto surgical program in general surgery in 1995. With over 2 decades of leadership in endoscopy and colorectal cancer screening, Dr. Kendall established an out-of-hospital endoscopy facility in Durham and served as medical director for 17 years. He's had numerous provincial quality management roles, including membership on the executive panel for endoscopy and the provincial quality committee. Dr. Kendall served at the College of Physicians and Surgeons of Ontario as chair of both the Premises Inspection Committee and the Quality Assurance Committee, bringing expertise in healthcare facility standards and physician quality improvement. Currently, Dr. Kendall works as a surveyor of surgical facilities at Accreditation Canada and has served as regional lead for endoscopy and colorectal cancer screening for the Central East Regional Cancer Program for over 15 years, providing strategic direction and clinical leadership for the program. So very impressive, Dr. Kendall. I can barely say most of the words in your bio. I'll now move on to introduce Dr. Rebecca Ray as the Regional Primary Care Lead. Dr. Ray obtained her master's in sociology at McGill University and a bachelor's of sciences health. What's BH? At Queen's University in Life Sciences. There you go. That's what you did. She completed her Doctor of Medicine at Queen's University and then went on to complete her family medicine residency at the University of Toronto Mount Sinai Hospital. Dr. Ray continues her involvement with Queen's University as a community preceptor for medical students and resident physicians. In addition to a busy family practice in Port Perry, Dr. Ray also is a community palliative care physician attending to patients in their homes as well as Oak Ridge's hospice. She provides primary care to Indigenous patients at the Mississaugas of Scugog Island First Nation Health Center, and Dr. Ray sits on numerous boards and committees and is also the primary care co-lead for the Durham, Ontario Health Team. She's passionate about health promotion and works tirelessly to improve the delivery of primary care services in the community, and she's been passionately serving the Central East Regional Cancer Program as the Regional Primary Care Lead with her extensive experience since 2023. So great leaders with us today. Really appreciate them taking the time to present this content and information. And I'll just move us along into a land acknowledgement for this morning. So I probably should have started also to introduce myself. So I'm Shannon Burke. I'm the Director of Regional Programs, which includes the Central East Regional Cancer Program, Screening and Prevention Team, and the Indigenous Cancer Program. I'm also the Director for the Department of Family and Community Medicine at Lake Ridge. And it is an honor to be with you all today. I wanted to start off to respectfully acknowledge that we live or I live, I don't know where you live, I live and work on the lands and traditional territory of the Mississaugas of Scugog Island First Nation. The Central East region, which is the region that our program supports, is located on Treaty 20 of Mississauga Territory, which is collectively known as the William Treaty First Nations. And that includes Curve Lake, Hiawatha, Alderville, Scugog Island, Rama, Beausoleil, and Georgina Island First Nations. I certainly want to acknowledge how grateful I am to the Indigenous people for their care and teachings of the land and all living things. And I think it's so important when we do these land acknowledgements, we're not just reading off where what treaty we're sitting on or what land or First Nations are close by, but really our commitment to community and to furthering and improving the relationship that we have with Indigenous communities and Indigenous peoples. Certainly, I've had the opportunity to learn so much about that in my role supporting the Indigenous Cancer Program. And I know that even in that role where I kind of support some of this work on the daily, I certainly still have much learning to do. I'm a second generation Canadian, and I know I specifically reflect on too as I send my 3 children off to school each day. I know that that's a privilege to do so, and it was a privilege that was taken away, a right that was taken away from Indigenous peoples with the 60s scoop and residential school system. So something we need to always acknowledge and remember. Um, and I do tend to be somebody who likes to do and act, and I'm trying to get better at listening and learning, and commit to continuing my efforts to grow in those areas, and to work in a health system that not only reflects and acknowledges Indigenous cultures, but really celebrates those cultures. And so as we take the time today to learn about colorectal cancer screening and different changes along the pathway, just encourage us all to take the time to reflect on our own personal commitments to reconciliation and actions we can take to pave the way for a better future, especially acknowledgement of National Indigenous Peoples History Month here in June. And thank you so much. I think we'll turn it over. I believe Dr. Kendall, will speak to his own disclosures probably, but I'll turn it over to Dr. Kendall first. Thanks so much.
Thanks. In terms of a conflict of interest, I don't have any particular grants or speaker honoraria. I'm speaking today as part of my job as a regional lead for colorectal cancer screening at Ontario Health. And I am given a small salary from Ontario Health, but that's my really only conflict or disclosure. Okay. Go ahead. Next slide, I think. That's it. Over to Becky.
Perfect. Thank you. Good morning, everyone. Similarly, I do not receive any grants or research support or speaker honoraria. I'm speaking to you today in my role as the Regional Primary Care Lead for our Central East Regional Cancer Program, for which I do also receive a small salary. I also do wear the hat as the Regional Primary Care Co-Lead for our Durham, Ontario Health Team, and I receive a salary for that position as well, although that does not present any conflict or create bias from this perspective. I sit as the Vice President of Durham Medical Society, also not creating any conflict for this presentation. As we go through, do you want me to do this, Shannon, or do you want to do this and then take us right to the first module?
You go ahead, Becky. Thank you.
Okay, perfect. So as we go through, so good morning, everyone. I'm Dr. Becky Ray, and I'm excited to be here today, speaking to y'all. I'm actually out as one of my other hats that I wear. Shannon very gracefully walked through our bios, which are always a little bit, I don't know, make me blush for sure. As my other hat, I'm a mom, and I'm very involved in our swim team. So I'm currently speaking to you from Vancouver, where I'm out with our high performance team for a big swim meet. So it's going to be lots of fun. If I look a little bit bleary-eyed, it's probably because I am, but looking forward to this talk today. As we work through our talk this morning, the slides so we acknowledge that there are many gender identities. Inclusive language can help screen eligible people understand whether screening is right for them. Many of the slides use terms male and female, but acknowledging that we need to think beyond those gender identities or to people's gender identity. Perfect. Let's move into module 1. So our agenda today is really to work through colon cancer screening and the changes that are coming effective July the 1st to the colon cancer screening program. And I'm doing the first module, so I'm really going to go through background. I'm going to try to speed through it because I honestly believe, like, as a family doc, most of our docs here today came to hear about the meat of the program, and Dr. Kendall is going to go through the evidence of the meat of the program. So I'm going to go through a little bit quickly the first part, because really we want to get to the meat so that you guys have a chance to ask questions. Yeah, that's perfect. So the first three slides just showed, just were really reflecting the burden of colorectal cancer in Ontario. So why do we care? Why is everybody here? Why are Dr. Kendall and I here? Because colorectal cancer accounts for 10% of all cancer deaths, and the lifetime probability is, reasonably high. So 1 in 22 for the average risk person, 4.5% males and females combined. But when caught early, 9 out of 10 people can be cured. So we want to be diagnosing colorectal cancer in stage 1, not in stage 4. And that is why we're here today. That is why we're here to talk about screening, so we can diagnose it early. We do acknowledge that colorectal cancer burden varies across sociodemographic groups, and that there are various disparities in colorectal cancer incidence, and some of those disparities may stem from structural and systemic factors, including income, education, social support, neighborhood disadvantage, access to primary care. And so we want to think about that as we're approaching colorectal cancer screening. Certainly, as a regional cancer program, we regularly think about that, about how we can reach some of these communities that might not have regular access to primary care. One of those communities includes the Indigenous community. So I have the privilege of being the family doc at the Mississaugas of Scugog Island First Nation, and interacting with them regularly, with that really fabulous community, and bringing screening to the community there. But acknowledging that compared to other Ontarios, First Nations people have higher incidence and mortality rates from colon cancer, as well as lower chances of survival following a diagnosis. And there's things that we don't understand about that. So really looking at how we can improve screening so that we're diagnosing colon cancer at earlier stages and changing the outcomes. Perfect. Excellent. So what is ColonCancerCheck? So the colon cancer screening program is called ColonCancerCheck, or lovingly referred to as CCC by us in the Cancer Care Ontario / Ontario Health programs. It was Canada's first organized province-wide screening program, launched in 2008. And when we talk about screening, we talk about screening average risk people versus people at increased risk of colon cancer. So average risk people, we're recommending using the FIT testing, versus in people at increased risk require colonoscopy. Dr. Kendall is going to get into the details, the meat of that. It's population-based screening program. So as you guys know, organized screening, population-based. It has you get a notification, you get a reminder you're due, you go for your test, you get your result, and then we monitor if follow-up is happening.
Okay, I think this is where I start. So the changes to the FIT program, the FIT program's now 7 years old, started in July of 2019. And since that time, we've had one supplier of the kits, Life Labs. And when you choose a supplier, obviously there's a price point, but obviously they also have to have infrastructure, which you all know about. How do they send stuff out? How do they notify people about inadequate samples or this or that? And also they have to make a bid for a kit that's going to be heat stable when it's put into mailboxes at 40 degrees. It might sit there for a couple of days over a long weekend in the summer, but it also has to be able to be heat stable to sit in a mailbox in the middle of winter. So these are all the issues about the actual kit itself, and the kit is changing, and so is the supplier. So that's one of the new things, but also there's program changes such as lowering the starting age and changing the eligibility for who gets colonoscopy or who is recommended to have FIT. So we can go to the next slide. So I'll just ask everybody here to read that, and then I'm going to get you to stop. Don't read it. It's gonna make your head explode. There's too much information there, and anybody who reads that is going to get frustrated, in my opinion. The takeaway for the changes to FIT are that the old 5-year group, the old 5-year colonoscopy group, is the only group that stays with colonoscopy. So everybody else is recommended to be screened with FIT. That includes people without a family history, but it also includes people who have aunts, grandparents, cousins, fourth cousins, uncles who had polyps. It's the only people who get colonoscopy now are if you have a mother, father, sister, or brother who had a colon cancer before the age of 60. And the other people in the 5-year group, if you remember, are you have 2 people in your inner circle. That's it. So it's a very simple. Colonoscopy goes for the 5-year group, which is 2 first-degree relatives or 1 first-degree less than 60. Everybody else is now recommended to have FIT. We can go to the next slide. This just goes, the other change was that previously, if you had a family history, say your father had a colon cancer at the age of 72, you were recommended to have a colonoscopy every 10 years, starting at 50. Now, since we're pulling back average risk screening with FIT to 45, it wouldn't make sense for increased risk people to start at 50, whereas the average risk person starts with FIT testing at 45. So now, if you're still a colonoscopy person, it starts at 40. It actually makes everything simple. The colonoscopy people have a first-degree relative less than 60 or 2 first-degree relatives. They all start at 40 or 10 years before their first-degree relative. Everybody else is FIT. And next slide. This just goes over people who get FIT need to have, I think it's self-explanatory that screening is for asymptomatic people. And similarly, there will be the program, I'm assuming, will be similar in that there'll be a hard gate, so that if you request a FIT kit for someone within 2 years, like 11 months, 3 weeks, 4 days, they'll just get a hard no. But if you wait until sort of 24.0 months, it'll be like, welcome back. So the same hard gate will be there. Next slide. Yeah, the symptoms of colon cancer. Let's get into the reason for the lower start age. There is, first of all, is bringing it in line with the changes that are happening in the breast cancer screening space. But there's also, you can go to the next slide, an acknowledgement. We can go to the next slide. An acknowledgement that colon cancer is happening in younger people, and people are presenting with slightly more advanced disease. The stat that I'm more familiar with here is that of all the cancers that happen in the population, probably 15 years ago, maybe 8% of those were people under 50. And that's been creeping up sort of decade by decade, and it's now closer to 10% of all colon cancers are happening in people under 50, which is the reason that we're screening back, that we're pulling it back to 45. Next slide. This is another way of saying the same thing, that people who were born after 1980 have a higher or a differently higher risk of colon cancer than people who were born in the 1950s. And next slide. And at the same time as colon cancer incidence seems to be increasing in those people, the incidence of colon cancer in older populations is not increasing. So this is a sort of an age-related issue. Next slide. And the incidence of colorectal cancer is elevated in First Nations people. I would also say that it's also elevated in Black Canadians, and those groups are known to have colon cancer a little bit earlier. In Black Canadians, it tends to be more likely to be in the right colon, and they're a little more likely to present with a little more advanced disease. It's not something that the screening program has felt is a significant enough difference to make different guidelines, but it is worthwhile when you're seeing your patients and thinking about screening. Next slide. I think we'll just, the key takeaway here, as I've already gone over, is that there's a reason for us to be screening people 45 and over rather than 50 and over. And if we're going to start screening in the average risk group at 45, we also need to make a corresponding change in our increased risk group. Next slide. Next slide. So before we get into the family history changes, I'm just going to summarize what we're doing in the average risk group. We're starting at age 45, and the reason is we're responding to changes in the incidence of colon cancer in that group, that we know there's more colon cancer happening. It also brings us in line with the breast cancer screening changes. And there's changes not only to who can get fit, but because of that, there's also changes for the increased risk group as well. Now we're on to what's the other change that's happening? Well, previously, if you had a first-degree relative, mother, father, sister, brother, who had the colon cancer at 62 or 85 or 99, you were still recommended to have a colonoscopy rather than FIT, and that's changing. And there's a rationale for that. When people have other people in their family with a colon cancer, your risk is increased, but not because you played under the same power lines with those people or ate the same food as those people. Your risk is increased because you share DNA with those people. And the DNA that's inherited that causes these colon cancers is, DNA repair genes, other proteins. So you share exactly 50.0% of the DNA with your mother and 50.0 with your father. And that same profile exists in your siblings. And you share 25% with your aunts, uncles, grandparents, and 12.5% with your great-grandparents. So if my father were to have a colon cancer at the age of 99, it's more likely that that cancer is sporadic. It's much less likely that 99 years and 9 months prior, he was given a gene that stayed stone cold silent for almost a century. So we would say that a colon cancer happening at 99 is very unlikely to be genetic or familiar. Whereas my father, if he had a colon cancer at the age of 39, we would say, whoa, that's very unusual. Something else must be driving that process. I wonder if there's a mutation going on. And now I'm really interested in checking everybody that shares half of that guy's DNA. So that's the rationale for age-related being differently interested in the age of onset. And we have always decided that 60 years was a threshold. And it wasn't that at 60 years, we're just not sure whether it was a mutation or not. It was, no, listen, if it's happening after 60 years, we're pretty confident that's not a mutation. And so this change is really a reflection of that mindset, which is to say, yes, colon cancers happen. It's a common disease. It happens in families. You might have a first-degree relative who had a colon cancer, but if it happened after the age of 60, it's correspondingly less likely to be from a mutation, and correspondingly there's less imperative to screen the people around you. So in the new program, first-degree relatives with colon cancer that happened after the age of 60 are recommended to be screened with FIT. We can go to the next slide. What is the evidence for that recommendation? The evidence that the ministry used were from two sources. One is evidence from studies that showed that either approach, FIT or colonoscopy in that over 60 age group, was equal. There was no clear benefit. So the study evidence is, hey, there's no difference. We can go to this option, and there's no deterioration in terms of colon cancer mortality in our population. And the second component was a meeting of an expert panel from various areas that sort of looked over all that data and said, yes, this is a sensible direction to go to. Next slide. These can be confusing numbers, but what I'll say is that This and the next slide, go ahead, are there to show you that the more relatives you have with colon cancer, the higher your average risk or your absolute risk of colon cancer is. That's a numerical demonstration of what I was just talking about. That when there's a greater statistical likelihood of mutations happening, that you're going to have a higher incidence of colon cancer. Of all the colon cancers that happen, there's a portion that are sporadic and there's a portion that are mutation. The more and more you hone in on that mutation type people, like clusters of cancers in families, the higher the cancer is going to be in that group. Next slide. So, and then that's the same thing. And the next slide. This is Quintero, and this is the study that I speak to patients about. It was in the New England Journal in 2012. It's a Spanish study looking at 25,000 people who did a colonoscopy and 25,000 people who do FIT every 2 years. And then you follow both groups out over time and see which group has more people with colon cancer in it and which group has more people dead of colon cancer in it. And the answer is that there's no detectable difference. That study was published in 2012 and was a big part of the evidence in support of FIT as a very valid way of screening a population. One of the other benefits of FIT was in that study, before they actually did the study and they had randomized people to it, they gave everybody an opportunity to switch groups. Like, hey, if you want to switch, you were randomized to colonoscopy. If you want to do FIT, you can, vice versa. And many more people chose to leave the colonoscopy group and be screened with FIT. That study was recently repeated in 2025 with very similar results. So it's now a pretty powerful longitudinal study showing that screening every 2 years with FIT is absolutely identical in terms of reducing colon cancer mortality, which is the only relevant metric here. We go to the next slide. Yeah, I think we've covered that as well. And screening with FIT is every 2 years. And the only people left being screened with colonoscopy, they're all going to be in the 5-year group. So if your patients are recommended to have screening with colonoscopy, they're all going to be 5-year people. They're all going to start at 40. Everybody else can be screened with FIT. If their FIT is positive and they end up having a colonoscopy and it's negative, like a totally negative colonoscopy, once you have a normal colonoscopy, that always gets you 10 years down the road. You don't need to start FIT again until 10 years after that colonoscopy. If they have polyps, one would hope that your endoscopy provider has said, I'm going to call this person back in X number of years. And of course, you don't need to do FIT until between that colonoscopy either. The next slide. The other change, this is a soft change in terms of it's very easy evidentiary wise to decide when people should be screened as an onset. The cessation of screening has always been a judgment call, and you're balancing, what is this person's 5-year mortality from their current issues, angina, pulmonary fibrosis, kidney disease, whatever else, and you put that up against the typical mortality of colon cancer. So in all comers, somewhere around 35 to 50% 5-year. So if you have a patient who's got congestive heart failure and has been admitted to hospital once, they have a 50% 1-year mortality. I'm not sure that I would be doing any colon cancer screening in that person. If they have a stage 4 lung cancer, I wouldn't be doing screening in that person. The long and short of the cessation recommendations are, and this is my paraphrasing, the current guidelines are you should screen to 75 or 74 and stop unless you've got a compelling reason to continue. And those reasons might be your patient had a polyp taken out at 73, or they had a colon cancer at 69 and they're still part of the early surveillance within 5 years or whatever. The new guidelines are going to be, you should probably screen everybody till 80 unless there's a compelling reason to stop, which is, your patient gets angina when they blink their eyes or they've had 2 double lung transplants or whatever. But again, you're balancing the 5-year mortality of colon cancer in all comers against your patient's predicted 5-year mortality. So that's the difference now, is that we're extending colon cancer screening to 80 unless you have to stop, unless there's a reason to stop beforehand, and we're rolling it back to 45. And the only people who are recommended to be screened routinely with colonoscopy from the outset is the previous 5-year group, and they'll start at 40. I hope that's a little simpler than all of the, first degree, 2 polyps before 60, after 60. Next slide. This sort of summarizes all of that. Fit kits will be available up to 85. Right now, with the recommendations of finishing at 75, they have always, for the last couple of years, been available up to age 80, but they will be available up to age 85. Next slide. Okay, I'll hand it back over to, is it Shannon?
Perfect.
Yeah, thanks.
Yeah, I'm going to go from here, Hugh. Yeah, thank you. So just a few additional changes for primary care. So in addition to the screening guidelines changing and the age changing, the lab and the device is changing. Now, that neither of those things should have any great impact on primary care, but they're important for us to know about. So the device itself is changing for a couple of reasons, but the device will look similar. So there's a picture of it on there. It's still a little plastic device with a top, and when you pull that top off, there's a little pokey stick that pokes the poop. So the device is changing, and the lab service provider is changing. So the current lab service provider is Life Labs. Effective July 1st, the new lab service provider will be In Common Laboratories. Because of these changes and the changes to the start date for screening, there is a change. There is a new fit requisition. This fit requisition is here. There aren't great changes. There aren't very significant changes to the fit requisition, but the fit requisition has been updated in a few different ways. Mainly, it really is the age of start is earlier, and then we can extend it out to 85. But we put the link here for the fit requisition so that you can have a closer look at it. And I think the important piece for primary care, sorry about that, is to update. So update your files. So don't wait until, July the 1st or July the 5th or, whatever date to find that new requisition. If you find it now, so now we've got everyone who's here, yay, early bird catches the worm. You've got, almost 4 weeks now to locate these requisitions, have your office staff update them in your EMR, and also update them on paper if you're using paper requisitions. For In Common Labs, so you do have to have an account set up with In Common Labs to get your fit results. If you have submitted, if you are here, you have very likely ordered a fit kit within the last 2 years. And so you will In Common Labs will proactively create you an account. So if you have ordered a fit kit in the last 2 years, stop worrying. You don't have to do anything. In Common Labs will create an account for you. If you happen to be a brand new family doctor, or you're, a resident who's graduating effective July the 1st and you've never ordered a fit kit, your account will be automatically created for you the first time you submit a requisition. So ultimately, there's nothing that we need to do to call In Common Labs to set it up. We can send our first requisition, and In Common Labs will set up our account for us. There is a separate account for each working address or location or fax number that you work at. So docs who work in 2 or 3 different locations will have different accounts within Common Labs. But again, this will happen in the background for you. If you have not ordered, so the account will be set up for you, but if you haven't ordered a fit kit within the past 2 years, you will need to verify your fax number. So it's a short process. ICL will fax, so Incommon Labs will send you a fax. You'll send in your first requisition. They'll create you an account. They'll send back a fax verifying. It's just asking you to verify this is the correct fax to send results to. Okay, so if you're getting a new account or they're setting you up accounts at your different locations, you will see these faxes coming through. I'm just telling you, there's nothing we need to do other than sign the paper and fax it back, but just so you can know what to expect and why that's coming to you, they're just verifying your account as we move to this new vendor. Fit results. So how are they going to come in? So fax is the default currently. Other direct options will include electronic medical records with the functionality to pull or push and or mail. If you want to, if you prefer to receive by mail, you will have to email your mailing address in to fit@iclabs.ca. That's the only people who have to do that, or if you actually prefer the results to come in by mail. The default is fax, but other options include EMRs with the functionality to pull them. I would say there is a little hiccup in all of this, and so we're telling you so that you might be prepared. We still have 4 weeks to fix, or Ontario Health and Cancer Care Ontario has 4 weeks to fix this hiccup, but it is a little hiccup at the current time. So the way, I work on TELUS PS Suite, my fit results come in through HMR directly into my EMR. That functionality does not currently exist within TELUS. Ontario Health, Incommon Labs, TELUS are all working together to try to fix this so that effective July the 1st or July the 2nd, this will happen, but there might be a little hiccup and we might be receiving things by fax at the very beginning. It may be a little bit frustrating, but it will be ironed out as we make this transition. The instructions will come. So this is what your patients receive. They receive this beautiful little sheet with their device. It's very similar to the previous device. Really, the only change is that it's a twist to close cap instead of a snap closure. So the purpose of the twist to close is hopefully there'll be less specimens that leak and less rejected specimens. Some specimens are rejected because they arrived at the lab leaking. And if that's the case, we can't ensure that that's actually an accurate result. And so those are asked to be redone with the twist to close. Hopefully that will be mitigated. Also, the instructions are available in 30 different languages. So you can go to that web link there and we'll provide you guys with this information. So if you need instructions in a different language for your patient, you can certainly access that. During the transition, so what are we going to do? So until July the 1st, you order the same way. So just keep ordering your fit kits the way you do right through until the end of day on June 30th. Don't send anything to Incommon Labs trying to get ahead of the curve. Life Labs until end of day June 30th, effective at 8 a.m. July the 1st. You will send all of your requisitions to Incommon Labs using the new Incommon Labs branded fit requisition. And don't send anything to Life Labs. So next slide. There will be this transition where labs that you had ordered in June are being returned to Life Labs. If you order something June 30th, it went to Life Labs. July 1st, it went to Incommon Labs. Don't worry about it. All of that is sorted in the background. You will be getting results back from both Life Labs and Incommon Labs for the first year. So for a whole year, there'll be that transition where anything ordered by Life Labs before June 30th is still going to be processed as patients return it. And then effective July the 1st, 2027, everything will function through Incommon Labs. So this actually is Dr. Firuzabadi will be happy to see this key change. So some of the big headaches in primary care, and Dr. Firuzabadi already indicated that one of the headaches is that we send out a fit kit and then the patient doesn't return it. And then we get a reminder and then we order them another one and they don't return it. And so that, does primary care actually need to be involved in that? Cancer Care Ontario is working on that in the background. They're aware of that. And one of the ways to improve screening is, perhaps to empower patients to order their own kits and, take charge of their own screening, but also take some of these, what we see as administrative tasks away from primary care. So working on it, we are aware of it. We've escalated it to Cancer Care and they're working on it, but it hasn't been implemented yet. But one of the things that has been implemented is if your patient submits a fit kit that is rejected because it was leaking or there was an invalid result, it takes primary care out of the mix. So that actually the lab will just resend the patient a letter with a fit kit to say, your specimen was invalid or your kit was leaking, you need to submit a new one. So that is a really great improvement on the system that can be celebrated, and we are working on other system improvements in the background. Just a few resources and supports for patients before we get into questions. So correspondence letters. So this is actually really important. Like your patients, and we hear this all the time in primary care, right? Patients will call and say, oh, I got my letter. I need to book my PAP. I got my letter. I need my fit kit. So there's a really neat, this is a neat tip for our primary care providers. You can sign up for your name to be on that letter when your patient gets it. So when your patient gets the letter to say, you're due for your colon cancer screening, it will then say, Dr. Ray believes colon cancer screening is important and wants you to have your colon cancer screening test done. There's really good science that simple statement, having your doctor's name on the letter, increases screening rate. So you do nothing and more of your patients get screened, less of your patients have colon cancer, and everybody is happy and healthy. And so I do encourage docs to sign up for physician-linked correspondence. We can provide that information in the post package, but you can also message Caitlin Loudon, who will, you guys all know Caitlin Loudon because she helped you get set up for this, but she can help you with that directly. And it's a really, really great tip to improve screening by doing nothing. New, so this is new. This is also an improvement on the system. So if patients were mailed a fit kit but haven't returned it after 2 months, they'll get a reminder letter. So Dr. Firuzabadi, this is another way to mitigate that. So it's one of the steps that we're going to do. So if you've ordered a fit kit, it's been sent out and they haven't completed it, in Common Labs will then send them a reminder letter at the 2-month mark to remind them to complete it. So hopefully we won't be getting as many of those letters back. So we do expect that more kits will be returned. I do have just one quick comment about that. So I have a really, just a great story. I had a similar episode, I had a patient, actually an Indigenous patient, so at higher risk of colon cancer. I had ordered, I think probably 3 or 4 fit kits over time. None of them had been repeated. And, each time I was actually just reordering it and asking my staff to call him and remind him to do it. When I received the last one recently this spring, I actually called him and I called him into the office and I chatted with him and I said, listen, I like colon cancer. I care about you. Colon cancer screening is important. You're actually at higher risk because you're Indigenous. He did his fit kit. It was positive. He went for his colonoscopy right away. Actually, he got in, I think, within a week or 2. And he was diagnosed with he was diagnosed with what they thought was an early colon cancer, but the pathology actually came back high-grade dysplasia. So this is a story. This is a success story, right? Like this is a patient where we have now prevented a cancer for this patient by just talking to him about the importance of it and reminding him of the importance so that, when we are just sending the kits, patients might not know. So when you have the opportunity A, tell your patients why we're sending the kits, why we care about screening, because it really can make a difference. So now this gentleman's he's going to have he's going to have a little bit of his bowel removed because of the grade dysplasia, but he's not going to have colon cancer. So it really is a success story. There's a fact sheet. So if this is going to help you with transitioning, with helping to educate your patients, or if they want a little bit more information about colon cancer screening, you can upload this and just give it to patients as a handout. For unattached patients, so we're doing working on attaching patients in Durham region. We're actually doing a great job. Thank you to all of you. But there are still some patients who don't have a primary care provider. They can call 811 and request that a fit kit be mailed out to them. And then if that fit kit is abnormal, Ontario Health and Cancer Care Ontario, we have regional docs actually who will then see those patients who are unattached and have positive fit kits to arrange for them to have colonoscopy referrals. A few supports for providers. So just link into Colon Cancer Check Hub if you're looking for any specific resources, or email us your team and we'll help to connect you. But this is a great resource here. Your screening activity report. I know we have so much to do. Screening activity report is a great way to monitor your screening over time and to identify, if you're really motivated or maybe you have hired a summer student and you want to have something meaningful for them to do over the summer, using your screening activity report to identify patients who are due for screening is a great way, because you don't just look at how you're doing. It's not just a report card. It's actually a tool. So you can dial down and drill down to who's due now, who's overdue, who's due in the next 6 months, so that you can start to recall those patients in for screening, or order their fit kits, or, have one of our local docs actually hired a summer student who called these patients and explained the importance of screening to them last summer. Just another shout out for Indigenous awareness and cultural training. There is a really fabulous, so Ontario Health has an Indigenous relationship and cultural awareness course. It's self-paced, it's free. There's 13 courses that really cover the whole history of First Nations, Inuit, Métis, and also urban Indigenous people. So I encourage you to check it out and complete it at your own pace. And as always, we have a really fabulous team. Thank you to our team. We couldn't do this. I think I can speak for Dr. Kendall as well. We couldn't do this without our amazing team. They're a great resource. Please reach out to our team if you have any questions. Cancer Care Ontario also prepared these great resources for us and has a strong team working as well to help improve cancer screening. Thank you. Turn over for questions.
Thanks so much, Dr. Ray and Dr. Kendall. Always a great job. I really appreciate you taking the time to give all that information. Lots of information. I see you've been double tasking and answering some of the questions in the chat. So thanks for that. I think a lot of them were answered, but just the opportunity for folks to put up their hand or put more questions in the chat or Q&A. We're monitoring both. I see there was a question from Dr. Leahy, but I think you answered that just recently, Becky. How does the process work for unattached patients or those living in long-term care homes? So, I don't know if you want to touch on the long-term care home piece, but that was in the chat.
Yep. So long-term care homes, so the most responsible provider can order fit testing in a long-term care home, again, per the guidelines. So up to age, so the program is to age 75, but please consider the appropriateness of ordering screening beyond that, depending on your patient's situation.
And then there's a billing question in the chat as well. Is there any change to the $7 Q150?
No, these are guidelines, not changing the Q150 code. So OHIP hasn't changed their side of things. This is an Ontario Health Cancer Care Ontario-led initiative. But I guess I would remind the Q150 code is about counseling, right? So that is not just ordering the test. So, if we do take a minute when we're with a patient to talk to them about the benefits of colon cancer screening, assess their risk to determine, are they average risk or are they at high risk? Are they are they one of these patients, as Dr. Kendall said, who has a first degree relative under the age of 60 with colon cancer? They need to start their colonoscopy. Are they in the colonoscopy stream? Are they average risk? And that by talking to them, you build the Q150 code. Okay, it's not just an ordering code.
I might just add as well, one thing I was surprised that Cancer Care Ontario didn't put in the slides, so just a piece of information for people to have. Under the present FIT program, patients can return their kits to Life Labs if they don't want to put it in the mail or if that's somehow difficult for them. There is now the opportunity for patients to return things to Rexall pharmacies instead, because I don't know if anybody knows of where an ICL Labs is. I certainly haven't seen them on the street corners like I see the Life Labs all over the place. So now if your patient can't put the FIT kit in the mail for whatever reason, they can bring it to either, this hasn't changed, but a First Nations health center can accept them, or the Rexall pharmacies are accepting them. And then there's a question probably again for you, Becky. Is there an incentive for positive FIT? And I think that's for the unattached population and attaching through Health 811. I don't know if you want to speak to that.
I was just actually replying to that. So yes, there is a billing code for taking on a new patient or rostering a new patient who has had a positive FIT test. So if they're already rostered to you, there's no code, there's no incentive. It's if there's an unattached patient, positive FIT, and you roster them and enroll them and say, yes, I'm going to be your doctor and take care of you from now until, eternity, then you can bill the Q code for that, and we will find out what it is, hopefully before the end of the webinar.
Next question, any change in the 2-week time from test to mailing? I guess that like once the patient's done the sample and they need to return it, is there any change in that timeline? Maybe Dr. Kendall, are you aware?
I don't believe so. That is test kit specific. So that has to do with the reagents in the test kit and their efficacy when exposed to the atmosphere and or temperature. I'm assuming it's going to be unchanged, but it's test kit specific, and I haven't seen any new direction on it.
And I'll just add too, Cancer Care Ontario Health has mailed out sample FIT kits to primary care providers. You should have received them this week sometime in your office. If not, maybe they'll show up next week. But they're obviously not to be used for patients, but they're samples so you can teach and educate and show patients. And within there are those instructions, so it will confirm the timeline for returning, mailing back the kit. Go ahead, Dr. Kendall.
So I just wanted to follow up on that 2-week question. I'm not sure I answered it the way it was understood. Once the patient has the kit, they can return it whenever they want. The reagents will be stale dated and the kit will be refused. It used to be 6 months, now it's 12 months, but it will be refused if it's been open for more than 14 days. So they can keep it closed as long as they want. They can go on their France vacation and leave it closed in their home and come and do it when they get back. But once they've opened the kit, if it's not returned in 14 days, the lab will be aware that the reagents have stale dated, and then it will be refused. But it's only when it's been opened.
Yeah. And I know, Dr. Kendall, you do a a great talk around this about, you know, the importance of telling patients, like, don't just put this, when you get it in the mail, don't just like file it in your junk drawer, like go and put it beside your toilet so that, you know, it's something that's front of mind when the urge presents itself and you don't have to go rifling through a drawer. So
I actually just tell them to take it out of the envelope, because when it comes in the envelope, I say, like, it looks like a CRA notice or a driver's license renewal, whatever. And once you realize it's neither, you will file it beside the phone or put it in a drawer. And that's very how it. So I just say, when you get it, just take it out of the envelope, because it will be the plastic kit and the instructions. And no matter whether they're at the bottom of a drawer, beside your phone, or behind a book, whenever you see it, you'll say, "Ah, I got to do that." But the envelope's just a little too easy to ignore.
great. Any other questions from the group? Or last minute pearls or pieces of wisdom from Dr. Kendall or Dr. Ray? This is great. Okay, well, thanks so much for joining, everyone. I hope you've had some good information on this Friday morning, and you know, happy Canada Day. You're getting a new fit kit. How exciting, right? So thank you again. We'll mail out or email out, not snail mail, but we will email out the presentation slides from today, right, Caitlin? Before I commit to that, I think we can. And then we have this recorded, so we'll send the link at the very least. I think the slides are okay to go to. But thanks so much, Dr. Ray and Dr. Kendall, for your time and great presentation. And thanks to everybody in the group for the questions. It's been great.
Thanks, everyone.
Thank you.
Have a great weekend.